Great. All right, so this is a little bit challenging. Obviously it's a huge topic. And so I'll try and address that. Disclosures, the only one really here might be the Celgene Amgen one, which I'll talk about at the end. All right, so this slide kind of comes off what Ken is talking about as well, that when we think about what are we trying to do with comorbidities. So skin heals up, right? If you treat somebody effectively, the skin looks pretty normal and doesn't carry a permanent anything, really. There probably is some immunologic memory sitting in there, but it looks good. And patients are kind of happy to get to some degree. I don't think you can rely on the patient to get to the intensity of treatment that Ken is talking about, where you may have to really drive down the psoriasis in order to modify some of the comorbidities, because they're afraid their script is going to run out. They're going to change over at the end of the year. Their job is changing. They're afraid they're not going to get approved for the drug, so they hoard it and they skip weeks and those kinds of things. So they will seem to titrate their clearness to what seems satisfactory to them, which may not be what we intended. And so they kind of have these partial responses when they could have complete responses in many cases. But that's the skin part. Then on the other comorbidities, some of those are not so reversible. So for instance, psoriatic arthritis, if you've got joint damage, you've got joint damage. You can maybe reduce the acute inflammation, but if the joint is actually structurally damaged, it's not going back. Arterial calcification, once you've got a coronary artery calcification, it's not going away. It's there. And so, if a patient is highly depressed and commits suicide, permanent. Cardiovascular MIs are strokes. These, create scars that are just there. Renal damage, and then even brain damage from sleep apnea or chronic inflammation that may affect the balance of, neurologic function, which may be more durable than just the acute level of the cytokines at this moment. So these are kinds of things to think about. So what's our goal when we talk about comorbidity management in psoriasis? So one of it is, as Ken was talking about, we want to mitigate the comorbidity progression. So if the psoriatic arthritis if you can do it right, you can maybe start therapies that are appropriate and keep the psoriatic arthritis from doing any more damage to that joint, or prevent an MI, maybe, so that kind of thing. So the other would be, it's who are you treating, right? So is it all psoriasis patients or is it some? So I think the data is pretty clear that there's an at-risk population for cardiovascular disease, and there's an at-risk population for arthritis, and there may be some overlap. And there's, so there are these different populations that when we try and talk about psoriasis in general, I think we lose the picture, and I think it's harder to get good data because everything's diluted with everything else. So that's where this concept of endotypes comes in, which is where you can look at a couple of patients who look similar clinically, but if you look at the pathomechanisms that are being used to drive their psoriasis and drive their comorbidities, it may look like psoriasis, but it's a little bit different molecularly. And then those are complicated analyses, as you'll see. Can you drive that down to a little lab test that's going to predict everything based upon that? So that would be kind of the idea of having a simple test that we can use as clinicians that is reflective of this very complex pathophysiology that's happening in patient group A versus patient group B. And then, of course, we'd love to be able to prevent onset. Like, okay, here's a group of patients and they have this molecular pattern, and they have the pattern that says you're gonna get psoriatic arthritis, so you better start treating for that before they get it. So that was like Ken's slide that he showed, that there was less psoriatic arthritis happening in the treated group. So what is an endotype? I kind of explained a little bit, but this would be subgroups with multi-parameter patterns that are related to their distinct underlying mechanisms that are driving the disease and the comorbidity of the disease. And so we want to predict them. And we also want to know, do they have differential treatment responses? So, which, with, some of our biologics, they treat almost everybody, but we don't know whether they're treating the underlying comorbidity that that patient may be at risk for. So we want to be able to predict that. So what this assumes is that there's some linkage, right, between what's going on in the skin and what's going on in the organ. That if you're expecting one treatment to both treat the skin pathomechanism and treat the pathomechanisms that's going on in the organ with the comorbidity, you have to have a linkage. We don't have great data for this, but the idea would be that when a cell, for instance, on the left here, this is skin biopsy of lesional psoriasis, and here's a capillary loop, and here's reedy pegs, and here's a vessel. And the green is the cytokine IL-6 here, but it's just, you can see how green it is. There's a ton of IL-6. There's many other cytokines and mediators that are there as well. So if you're a touch and go leukocyte, that as you course through here, you touch for a second and your adhesion molecules get activated. You get stimulated by IL-6 and IL-1 and everything else that's coming out, and IL-17 and interferons. And now you go back into the circulation. You have the opportunity then to go adhere into the joint or into the vessel wall and create havoc elsewhere. Or it could be it could be the mediators themselves pouring into the vasculature and then circulating systemically, and also affecting the biology that's in distant organs. And so, how do we get to that? This gets kind of complicated because this is being affected by your underlying genetics, but not just the genetics, because you have your epigenetics. What infections did you get exposed to? How much dioxin was in the toxic waste dump in the next door lot that you're living next to? And, and what are you eating, and what's your microbiome doing? All of these things are coming together, and it's just too complex, right? To be able to say, signal response. Here's a cell that got stimulated, it makes IL-17, you have disease. It's obviously more complex than that. So the promise then is that, well, we can't think that through that well. Can we use the big data bioinformatics capabilities that are now everywhere? You hear about AI. So can we combine these the medical informatics in patients' records with lab-based informatics with very high density information, and then identify these endotypes? And that's kind of what we've been working on, and others have as well. And then this Lee Hood quote, I think, says it very well. We'd like to identify the earliest markers of disease and reverse them before the disease can develop. That would be great, right? But for now, are we at the edge of being able to have actionable health information to identify the at-risk comorbidity patients? And then can we make treatment choices? And also the intensity of treatment, I think, is also a variable that we need to keep in mind. So how do you do that? So this is a diagram that somebody put together, this fellow Dash a few years ago, but this is pretty much what we're trying to do. So on the right, obviously we want improved outcomes, smarter, cost-effective decisions on behalf of our patients and our payers. And to get to that, we have to have analytics, that do different things. They describe, they diagnose, maybe they predict, and then hopefully help us treat. So this data, this analytics comes from some data somewhere. And so what kind of data? So clinical data, a CBC, absolute lymphocyte count, the neutrophil lymphocyte ratio, the monocyte platelet aggregates. These are typical predictive values that you can use to kind of stratify risk for cardiovascular outcomes. You can go in the public health record and see, did they get vaccinated? Did they have a reportable, STD? You can go in, these are hard, very numerical kinds of data. When you get into the electronic health record, it gets way messier because physicians are busy. We write lousy notes. We don't put things in the right place. So trying to get workable data out of our busy, quickly typed or misspelled dictation, is not actually very good. And then you can go into the omics data, which would be like looking at the proteome, all the proteins expressed on the cells through flow cytometry, or in the plasma, or the genes that are being expressed in the various cell types, that kind of thing, or the genetics. And then you can get sensing data. So you may have your patients running around with a watch or some kind of detector that tells you that the heart rate is this and the blood pressure is that and the skin resistance is this other thing, and you've got 24/7 monitoring, and it's loading up, and you've got this ungodly amount of data, which we tried, and it's like, ugh. All right. So this is kind of a fun one that we did, and we tried to identify cost over a couple of year period in our electronic health record, which has cost it built into it because it's a Medicare accountable care organization data set. And we had RNA gene expression on this subset of patients for whom we also were able to dig into the electronic health record for this thing. And so what we're seeing is what we would call endotypes. You see, this group has red genes here and blue genes there, and this group has red genes here, so these are patients. Each vertical column is a patient, and these are all genes that are being expressed. And then you can't see it, but loaded in here are demographics like age and I can barely see it myself, but I think the third one down is a monocyte protein marker, and then the PASI, and then in the black here is cost. So there's a bit of a relationship between the genes that are being expressed and the total cost of care, all things, not psoriasis cost, all care over this 2-year period. So, okay, I don't know what to do with this. It says something, but how do you connect that through, right? So, but there's something going on there, and we would love to know this, or healthcare payers would love to know this, to say, well, who's more expensive and who's less expensive? And is there a transcriptome that goes with that they can do? And then don't insure the people who are going to be high cost. No, I didn't say that, but there are people who would think that, right? Or how do you identify them and put them in prevention programs that are going to be more monitoring of their health, and leave the other people alone because they're going to be healthy, right? So that would be. So let's take a look at this in a little bit more realistic kind of thing. So this is work from several folks I'll mention as we go along, where we're now starting to look at psoriasis and look at a couple of comorbidities, atherosclerotic vascular disease and psoriatic arthritis, taking into account some of this complex data that kind of sums up into the transcriptomes of the leukocytes. And so this is work from Cheryl Cameron and Dustin DeMayo and Tom McCormick. So we're looking at here, the phenotype would be psoriatic arthritis. And we're looking in the blood, and we're seeing all those patients vertically, genes horizontally. And then if you take a look at all those genes, then you can say, well, what pathways are these genes, when you have these genes up and those genes down, what does that mean? What pathways are likely being utilized? And then over here, going across, these are patients vertically. You can see there's a cluster of patients over to the left that have a very high p-value and a very high fold change that associates with psoriatic arthritis. If you're green, you're a psoriatic arthritis patient. And so there, a couple of these are quite good, one of them being cholesterol, another one mTOR, and obviously TNF is just the middle one, which I think gives this some face validity. But what's interesting to me here is that on this left side are the psoriatic arthritis patients are all on the left, not on the right. So that there is some mechanisms that seem to be more active in them, but there's these red ones. So the question there would be, in a big study, if you did the same thing, are those red ones the ones that are at risk for psoriatic arthritis? So I'm just using this as I don't have that data, but that would be the provocative question from data like this. And so, and then, to get more specific, because this is like basically all the leukocytes. What Cheryl Cameron has been doing is oops, two of those. Back one. Not sure where I'm pointing. There we go. So this is where, instead of looking all the leukocytes, you're looking every cell in a whole bunch of patients, and just neutrophils, though, a purified cell population, so that we have a more focused look, not being diluted by T cells being averaged with monocytes and that kind of thing. So, and what you can see here is that the psoriasis neutrophils without arthritis are quite different in their gene expression than the neutrophils from patients with psoriatic arthritis. So this is pretty dramatic result that she's been getting. And so what she's going into is trying to find which of the most really critical genes that are really distinguishing. They'd be the ones that sort of at this extreme and at that extreme. And there's some interesting cell types that are kind of coming in here, which are progenitors that are what's called pseudotime, that lets you see the neutrophils as they're maturing. Even though this is a snapshot, you're seeing neutrophils over the last several hours, because neutrophils don't last very long in the circulation. So a very cool kind of data. So she's working on some of these trying to figure out some of the markers that could then be converted to a more simple kind of test. So, okay, so let's look at atherosclerosis. So here we're using coronary artery calcification as the surrogate. It's a hard number, right? So it's a sequential low dose CAT scan, and in our hospital we do these for free, basically. And so there's lots of patients in our hospital system that have these values. So it's the whiteness in the coronary arteries, and it's measured in these Agatston units. And we can see that there are, if we were to look at the bottom, that there are two groups of our patients, and there's a statistical difference between in both also the 10-year Framingham and the AHA, ASCVD risk in the patients between those who have high and those who don't have high scores in our group. And so this is work that Dustin DeMeo has been working on. He's a medical student, took a year out. And so what we're looking at now these are the patients vertically. I'm trying to keep this constant in this orientation. And here's some genes going across this way. And you can see that the CAC score, which is right here, going across, the patients who have which have these circles, those are the ones greater than 100. All of them are on the left side. And the patients who don't have any coronary artery calcification are on the right side. But some of these patients are missing data. But just to know that this is where these guys all fall. So there are genes that are associating with those who actually have calcium, and then a group of patients who we don't know or don't, that are also sitting over there with those same kinds of gene patterns. And so going into that more deeply, what he's able to do is this, what's called a volcano plot, and look at genes that are highly significant and have a high fold change that are might be useful as biomarkers. And so some of these actually are pretty good at being exclusive and non-overlapping in terms of being able to predict, but they're not the kinds of things that are that easily convertible into a blood test. So would rather not have to do RNA, PCR, just a little bit more complicated. If we can find like a surface protein that you can do by flow cytometry, that would be better, or an ELISA on a plasma. So that's the kind of thing that he's trying to get to. Okay, so then you can also look, remember I mentioned about the pathways. So you can look at the pathways also. And so here's where those high CAX patients all segregate. This is just allows the pathways to segregate. And this is where the CAX patients happen to land. And so there's this endotype here that correlates with the calcium expression in the arteries. And it's not related to PASI, which a high PASI has a plus sign and more greenness, or maybe a little bit with age. We know that age correlates with this, but you can see that there's a lot of interferon alpha and gamma happening here. There's TNF signaling, which is again good face validity for the data set, and which then says that okay, there may be something that happens. And what we're trying to do now is going to a much larger data set where we within our hospital that has the non-psoriasis patients. So we have to clean out the psoriasis and then look at the non-psoriasis patients and see if we get this same gene set, or is this gene set specific to psoriasis. I'm going to jump over this slide, and it's just basically to transition me to monocytes. So meaning that monocytes are obviously involved as a sensor. When we see those interferon alpha and interferon gamma, it's not that we're seeing gamma itself. These are responsive genes to the presence of interferons, which are well demonstrated in psoriasis. But we're interested in these monocytes as biosensors, and we're working on this for a little bit. And we like them because, like the neutrophils, they're short-lived. They give us a sense of what's going on today or the last day or two in this patient right now, and easy to get to. So what we've found and been working on is that this little blob here, when we look at blood monocytes, this is control patients don't tend to have this blob, but this particular psoriasis patient has a really prominent blob of these cells, and it turns out that that blob there it goes, are comprised of doublets. So these are double cells. We can visualize them in the upper right. And you can see that pink thing is a platelet. A lot of them have platelets attached to them. So these are circulating in our blood. All of us have them. It's a little disturbing. And some of them, there's 3 cells attached. But the psoriasis patients, a subset of psoriasis patients, if I could get this to go, there's one more arrow, are very high in these doublets. So we would then consider that like a relatively easy marker of a subset of patients with psoriasis who have and we have the program on these cells. They're very hyper adhesive in their markers and in their genes, and activated. All right. So now we're transitioning with these monocytes, and we had a thought that if we wanted to be predictive, we want to take a drug treatment that is not so perfect, right? That treats a subset of patients. And we know that, for instance, PDE4 is very highly expressed in monocytes. And so it's the target of apremilast. And the beauty of apremilast in this context is that not everybody responds. It's only a subset of patients, maybe 25, 35%. I don't know, what do you think? But that's, there's a subset that clearly do quite well, and then another group that doesn't do so well. So it would be able to give us some separation and prediction. And so we looked at doublets as a main outcome measure, actually, and their RNA. So we're looking at the protein expression and their functionality and their RNA. And then we followed them. And what this arrow is pointing to is the apremilast response. So the patients are organized in this to show that the red are the responders. Let's see, make sure that's right. No, I'm sorry. The red are the non-responders. Sorry. I can't see that from where I am, but these are the non-responders and these are the responders. And this is enriched because to get into the study, you had to have at least one of 3 monocyte abnormalities, which is not worth talking about right now. But what's happened here is that this is the doublets. So it turns out that the patients with high doublets all clustered into the apremilast responders. Plus, we have an endotype that appears distinctive from another endotype in the non-responders. So we have both a gene program and a relatively easy biomarker that then allows us, and this was all done predictively, this was done prior to treatment. The point of it was to say, could we enrich the responders? And so what this tells us is that if you have these doublets that are high, and this particular gene program, it turns out about an 80% likelihood to respond to apremilast, oral apremilast, which is way better than the general, what happens normally. So that's kind of cool in the sense that we can now start to, take an endotype, convert it into a semi-reasonable blood test and have some predictability for treatment response. So I'll just stop there and just thank all the folks that work on this. So Giovanni and Andrew are working in the lab. Dustin and Mark Cameron are the major bioinformatics folks for this. Jackie and Cheryl, who I talked about some of their work. Tom and Neil, who do a lot of this, and various supporters. And the things that I like to do as we approach winter, the surf gets better in Florida and the snow starts to fall. This is what I really like to do. All right.
All right. So we have about 13 minutes for questions. Hopefully Ken is still on the line. And anyone want to introduce a question from the audience? Yes, Mahira.
Thank you very much.
Here we have a microphone coming right there.
Thank you very much. Amazing 2 presentations. I have a question though for you. You mentioned that comorbidities are irreversible. But don't you think if we early control the disease, at least the comorbidities will be easier to control? I know, like, if we have mutilating arthritis, it's irreversible. But I mean, is there any proof that cardiovascular disease, diabetes, hypertension, any of those comorbidities, if we control psoriasis, they will be better managed? Or we really don't? I understand some of the dermatologists feel that they can treat those diseases by giving the patient a biologic, but they need to go to their physician. But maybe doesn't controlling the disease early enough help with that? It's just a thought I would like to run by you. Thank you.
Right. Yes, I agree with you that being able to identify the right mechanism in the right patient, like the blanket that treating the patients intensively will fix all the comorbidities, I don't think is quite right? But I think that in the right subset of patients where they actually have the liability for that comorbidity to occur, if you were to treat early enough before irreversible changes occur, then yeah, I mean, that's what we would like to do, is be able to prevent those comorbidities. But what I think we don't know is, does a treatment do all the treatments, like whether you're using an IL-17 inhibitor or a 17 receptor inhibitor or a 23 inhibitor or a 23/12 inhibitor, are they all equal in their ability to prevent cardiovascular disease, psoriatic arthritis, renal disease, hypertension? It probably not, would be my guess, that there's some patients for whom the pathophysiology with gamma interferon inhibition is probably important and others for whom it's not. For those where 17 inhibition may be great for the psoriasis, but maybe it's not complete enough for renal disease. I'm just making it up. I don't know. I just don't know. I think that's the big unknown for us in our field.
Joel?
Hey, Ken, hope good to see us all here. You're a giant man in the screen there. Good to see you, and Kevin. A couple of comments and then maybe a question or two. One is, the psoriatic arthritis data that Ken presented. I think it's important for people to know that the observational data is very mixed there. And in fact, in that Jasandi study, when they did another analysis called a propensity score, they found the opposite, that biologic treatment was associated with a higher risk of psoriatic arthritis. And a paper Alexis Agdi led that I was collaborated on, we also found that biologics were associated with a higher risk of developing psoriatic arthritis. So sometimes these questions are very hard to answer with observational data. And I really think for our field to move forward, now we have so many effective mechanisms, we need to think about doing, larger scale, longer term pragmatic trials where we randomize people to one strategy or another, then really see who gets the most benefits in terms of not just their skin, but their comorbidities over time. The question I sort of had for you, Kevin, about the work you presented is that a lot of these patients already have atherosclerosis. They have elevated CAC scores. So the question is really, are you measuring people who actually, are you measuring coronary disease, or are you measuring the future risk of coronary disease, right? So could you sort of address that issue? And then the second part is, do you think there's a reason to think that treating coronary disease or atherosclerosis could actually improve psoriasis long-term? So the concept being that having atherosclerotic disease, which could develop very early, could either induce or aggravate or promote psoriasis progression. And therefore, what we really need to do is aggressively treat people's atherosclerotic disease to put them on a better trajectory over time.
I like your second question a lot. That I think that's true. If a person is at risk, for cardiovascular disease, there are ways to do that in the cardiovascular world that are imperfect, but better than what we have in psoriasis. And so we need to do that for those patients who have the risk. But you're right, the patients we're studying have the disease. But what we're so interested in most is those patients who cluster with them, who don't have the disease. Why are they over there? Why are they sitting red with the cardiovascular patients and not over with the blue in the non-cardiovascular patients? So that's the study that I would like to do prospectively, like you're describing. It would be to have a huge study, get the transcriptomes, see if those guys in the reds, kind of narrow it down to something more practical than what we're doing, and then and see, do they evolve, or which ones do evolve? I think these are, early days in this kind of thing, but I think you're exactly right. We're getting the hint from the patients who have it. The interest part is those patients who are clustering with them.
Andy. Oh, sorry, Richard.
Yeah, so if you can hear me or not. So great presentations, and good to see you, Ken. Too bad you're not here. So I just want to, I want to come back just to the definition part that Ken started with, because that's so important. We have to have a definition of what it is we're talking about and where we're trying to go. And so if we go back to the definition and we look at it, it says modify pathophysiology to give enduring benefit as opposed to symptomatic relief. Okay, so in other words, fundamental to this is changing pathophysiology, right? Altering pathophysiology. And, we go, then we're kind of going down this rabbit hole where we're going to, and it's great stuff. We're going to hear about, altering tissue resin memory cells, the transcriptome, and I guess the point I would come back to is, what are we really talking about here? We're talking about disease modification in the patient and in the clinical course. That's part of it. And Ken listed them. He said delay of disease progression, prevention of comorbidities, altering disease course, and delaying disability like cumulative life impairment. So why do we think, because I think this is very important that we go through this, what are we trying to do? And is this all purely linked to pathophysiology and mechanism? Or should we have a concept about actually symptom control or effective or nearly effective control, like complete remission, while patients are on drug? Because who said that you have to be able to give a drug, stop it, induce TRM changes to have an effect on disease course? You think about a 16-year-old girl that I have who won't go outside, who suddenly has 30% psoriasis. You clear her and now she's got a normal life and she's on therapy and her disease is altered on therapy. I don't know whether her genes are altered. I don't know whether treating her earlier made a difference. So I think one of the concepts should come out of this is what we're trying to, whether we have to go for this strict definition of pathophysiology alteration, or can we also talk about the benefits of early treatment? And also, what level of control do you need? Do you need complete remission, or does a 90% improvement work? Can you still get benefits in patients? And also, will those things impact cardiovascular and all the other outcomes? So I think I feel it's dichotomous right now. We're saying yes or no. And I think that we have to think that's certainly an important question. The TRMs and the IL-23s versus 17s, Treg cells, that's all fascinating stuff. I love it. But I think we also have to think in a practical clinical sense of where we're going, because it's also more realistic with the drugs we have.
So Richard, I'm going to agree with you 100% on almost everything you said, which I know is probably the first time that's ever happened. The issue is the enduring effect. You don't actually have to stop the medication. And I think that's important to remember, that it's not a stop and start issue. It's just that you have to demonstrate that over time, the outcome that you're measuring, the impact is enduring regardless of what goes on with the medication. So, the patient you talked about, the young person, they could have some developmental or educational issue, which they'll never catch up from unless they were treated. And having been treated, they will over time have a better outcome regardless of what happens in the future. And so that would be disease modification. The issue with pathophysiology is that in order to get those enduring effects, you have to do something to the disease rather than simply treat symptoms. And I think the best example that I can think of off the top of my head is, non-steroidal anti-inflammatories for inflammatory arthritis. They'll help symptoms, make people feel better. But if you stop them, or if a patient loses effect or something, you're going to go right where they were in before. And so that's not true disease modification. You can have, no one talks about with disease modifying drugs in MS for people to stop and start, though I should say there are drugs in MS that you do hit patients hard, and then you can stop and there's clear disease modification going forward. And that, I think, is actually probably the outcome we would all love to have, because that's something where you can treat, then stop, and the patient doesn't have to be exposed, there's no cost, and it does change disease over time. But the issue is really, in order to really get those fundamental enduring changes, I think the assumption is, and maybe this is an assumption that's not correct, you have to change pathophysiology. And I think I commented that changing pathophysiology without clinical outcome changes isn't disease modification, that you're not changing it, that you have to base everything on some clinical outcome that is applicable to the patient.
So I'm just going to finish, and I'll say I agree with everything you said except one thing as well. So there we go. But I think the point is, to me, is that true? Is it true that symptom control cannot modify the disease apart from pathophysiology? In other words, let's look at a 23 versus 17. Let's say 23s are more effective at knocking out TRMs, okay? But if both drugs, you have them on it and the patient is completely clear, okay, maybe one drug you can stop or increase the interval. But if the patient is completely clear and retains that improvement, and the symptom is the thick raised scaling plaque, that's gone in both. You have, let's say one, you haven't as effectively changed the pathophysiology, but the patient's clear. You are impacting the disease outcome. You are impacting the patient's quality of life, and presumably you're impacting the progression of inflammatory related comorbidities. So I guess that's what I'm saying is, I think as we say pathophysiology, we hang our hat on that and we go down this rabbit hole. I think you got to step back and say, is it possible that you can modify the disease outcomes, inducing clearance or near clearance while on drug without having to stop drug, and recognizing that, whether you call that early treatment or effective treatment or something, but I think it should be part of the conversation.
No, I agree with you, Richard. And I also made the point that when you're talking about pathophysiological effects, it has to translate to patient, right? If pathophysiology without patient outcomes that make a difference doesn't really mean a lot.
I think we'll take one. Andy, do you want to make one more comment? Okay, go ahead.
I have
Yeah, okay, great. We have all day to make comments, by the way. That'll be related to
Question,
this.
Kevin, have you looked at the HLA-CW6 status of your responders versus non-responders, or to the presence of your monocyte biomarkers?
Yes, hey, we do have CW6 data. It's embedded in the data set, and we've looked at it a little bit. It's been more in the Stellara relationship is what pops up with that than it does with these other things. But others have reported that as well, but we've seen that.